Good morning, folks. It's Rob Timmings from ECT for Health here with our COVID bundle. This is video number 2 in our series that we're unpacking some respiratory physiology and a little bit of respiratory care of the patient with severe acute respiratory distress syndrome. So diseases like we're seeing with our COVID-19 patients or will be seeing. This is an attempt to put some education back into the online space, and I've joined forces with Brad from Bundle of Rays. So we're going to be turning out these videos fairly regularly to our subscribers. So I hope you're enjoying them. Alrighty. So today's episode, we're going to have a look at oxygen, the molecule, and pulse oximetry, the concept of how oxygen binds to hemoglobin. So oxygen, the molecule, it's a diatomic molecule. It's in a stable state when there's two atoms of oxygen joined together. That's why it's called O2. That's why it's called a diatomic molecule, because it's two atoms that are joined together. It's present in room air, in the air that you're breathing on atmospheric Earth, at 21%. Now, it doesn't matter what altitude you go to. I mean, you've probably heard that there's less oxygen up on, let's say, the top of Mount Everest. There isn't. It's still 21%. It's just that the air pressure is much less back there. And in a later video, we'll unpack just what that means. 21% of atmospheric air is the same as saying a fraction of inspired oxygen that is 0.21. So 0.21 is the same as 21%. And as you know, the oxygen is breathed in from the air. The oxygen molecules will diffuse into the blood, where they're carried by red blood cells. So think of your red blood cells as the delivery trucks. And inside those delivery trucks, there's molecules called hemoglobin. And I'm going to get Brad to unpack that a little bit in a few minutes. Why do we need oxygen in our cells? Well, that actually comes back to this idea that every single cell must burn fuel. Just like a fireplace has to burn wood or coal, or a motor vehicle engine has to burn hydrocarbons like petrol or diesel. At the end of the day, it can't burn something or oxidize something without oxygen. So cells are using fuel, burning fuel to make energy, and oxygen's used in that process. So without oxygen, we can't burn fuel efficiently. We can't make energy. Without energy, cells don't work. So if it's a brain cell, it requires oxygen to oxidize the glucose, or to help with the glucose conversion ultimately into ATP, which is the energy that brain cells use to send those electrical messages. Heart cells, they can't contract without oxygen. Liver cells can't do all of those liver enzyme things without oxygen. Skin cells can't do skinning without oxygen, and of course kidney cells can't keep kidding without oxygen. So how do we measure the oxygen in your blood? Well, we can measure it two ways. We can measure it with arterial blood gases. We don't use venous gases to measure oxygen in the blood. Venous gases are for measuring other stuff like pH and lactate levels in really sick patients. But to measure the oxygen in the blood, I can look at an arterial blood gas sample, a sample of blood taken from your arterial blood, and I can look at the pressure of the oxygen that's exerted in the plasma. So oxygen is carried in the plasma, the liquid of your blood, but it's also carried in the hemoglobin. In fact, 97% of all the oxygen that's in your blood right now is being carried in the hemoglobin molecule. So that's where the bulk of your oxygen's carried. And that's what we're measuring when we do oximetry. So I can look at your arterial blood gases and look at your plasma-bound oxygen, or I can look at your pulse oximetry and have a look at your hemoglobin-bound oxygen. Now, a hemoglobin molecule has 4 little receptors. I'm going to let Brad go through this in better detail with you, but it has 4 little receptors that hold on to oxygen, and when each one of those receptors is stuck to an oxygen molecule, it's at that point that we would say that this oxygen hemoglobin bond, or this oxyhemoglobin molecule, is 100% saturated. That's what that means. It means that all 4 of those little sites on that hemoglobin molecule is sticking to an oxygen molecule. Now, normally saturations are considered to be normal if they're over 90. I know most of you were probably taught some years ago perhaps that normal sats are anything over 96, and then a few years ago it went down to, well, we can accept down to 94. Well, the latest is that our oxygen saturations, anything from 90 and above, are considered to be okay. We don't need to oxygenate patients unless their SATs drop down below 90. Of course, with a special population like our COPD population, then we would have to be mindful that with COPD patients, we allow their SATs to drop even further. We probably don't really want to put oxygen on them until they get down to close to 88. So anything above 90 is probably okay. What is important is to recognise that oxygen is a drug. It exerts a physiological effect, so I suppose you could classify it as a drug. It's certainly not inert, and too much oxygen is a bad thing. It's quite dangerous, and we'll have a look at that a little bit later in one of our other sessions. So, should I be looking at saturations to determine the oxygenation status of a patient, or should I be looking at blood gases to determine the oxygenation status of a patient? And the answer to the question is yes. They both have value. They both correlate. Where SATs go up, so too does the PaO2. When the PaO2 falls, so too do the SATs. There's a few conditions wrapped around how that occurs, but you can be fairly reliant on saturations, providing you've got a good quality trace on your finger, a good quality pulsing of blood through the fingertip, that they're not peripherally shut down, really cold fingers on a cold morning. We're not going to get very, very good quality SATs trace. I mean, that SATs probe can sometimes be little more than a number generator in those sort of circumstances. So warm up the hands, make sure that the fingers are clean, absolutely make sure that there's no nail polish on there. What this machine is doing, this little probe that you stick on your finger, what that's actually doing is it's looking at the colour of your blood. It's not even looking at oxygen molecules, it's looking at the colour of your blood. The more saturated your hemoglobin is, the redder your blood becomes. And so it really just uses a little photograph or a little light spectrometry device in that probe to determine how red your blood is. So if your blood is really, really, really red, then it's going to give you a high SAT reading. So remember, it's got to see blood pulsing through your finger. So if it's dirty or there's nail polish or cold and peripherally shut down, you're not going to get a good quality trace. And therefore, those SATs are not going to be reliable to determine the oxygen status of your patient. It's in those circumstances that absolutely you would be doing arterial blood gases, particularly if your patient was sick or peripherally shut down. So that's our SATs versus our arterial blood gases. More on arterial blood gases in another session. As far as hemoglobin's concerned, that's kind of the champion here. This is the molecule that's carrying the oxygen. It binds with 4 oxygen molecules. I'm not going to spend too much time on this because Brad's going to unpack it beautifully in 3D for you in a moment. But about 50 to 75 trillion red blood cells are floating around inside your body, and every single cell has got about 250 million molecules of hemoglobin. So that's a lot of hemoglobin molecules sitting inside your blood. So there it is, hemoglobin, saturations, normal SATs, anything over 90, probably avoid oxygenating a patient unless their SATs drop below 90. I know that your protocols are probably suggesting to maintain oxygenation to keep their SATs above 90, 94. Many of the health services have, but that'll change because we now understand that too much oxygen is actually a bad thing. More on that in another episode. I'm going to let you over to Brad now, and he's going to unpack this hemoglobin a bit more for you. See you later, guys.
Okay, we're going to do a little bit more than unpack it. We're going to stand inside it. So we're inside a vessel here, and the hemoglobin is flying at us. So this is the power of virtual reality. We can go inside the content and not just unpack it, but visually break it down. And we're going to step from the vessel to a clinical setting. So here we've got a gentleman who we can see is dyspneic. I've just put some oxygen on him here, much like a mannequin, but we can actually see his work of breathing. We'll put this saturation probe into practice, like Rob's been speaking. We have saturations of 62. Now, understanding all the information that Rob has given you and applying it at the bedside is just so important. And in the next couple of weeks and months with COVID, understanding our practices and not just doing them is really key in terms of clinical escalation. So SATs are 61. We're going to want this guy either triaged or escalated to our docs and get him into a high dependency area. Now, the ability of VR to understand these details, the picture you have here is a program called Nanome, where we can literally look at the molecule and you can see that there's multi-users in this setting, and we can break the hemoglobin down and talk about its carrying potential. And this is the kind of thing we do at Bundle of Rays. And now that we're teaming up with Rob, we're going to be able to break these sessions down in a multimodal fashion to deliver you something that has meaning. So as you get some of these education sessions in the next couple of weeks, if you've got some feedback for me and Rob, feel free to tell us what's going on, because we want to give you something that's going to support you on the front lines. And we hope that this hemoglobin and oxygen video has helped. And take care out there. See you guys.